morning, everybody. To all the people who's just visiting on Saturday, welcome to the conference, the International Carcinoid Neuroendocrine Conference and Symposium for Patients and Medical Professionals. My name is Maureen Coleman. We're going to start the sessions almost right away. Just a couple of things. At the box at the back of the room over there, in the box is some contact information for people who wanted to share their contact information. If you take one and you see your information is missing, email me at Maureen C at Simpatico, and we'll somehow find a way to email you the contact sheet with your name added or something like that. We'll figure it out. Welcome to some new faculty today. Ralph Wong, Ernst Postema, and I think you just came in today. Ralph Wong, Dr. Ralph Wong, and Dr. Ernst Postema. Welcome. Today we're going to start a silent auction. Silent auctions are when you put your name down, you bid on beautiful items, many of which are made by our community and donated, and kindly donated. And you put your name down, put a price beside it, and then somebody else can put their name down underneath yours and put a slightly higher price, and so on and so forth until 9 o'clock tonight, at which point we're going to stop the silent auction and use our newly acquired Visa machine, or cash, or checks. We'll take your checks, cash, or Visa, or MasterCard, and the proceeds will help CNETS Canada. So, also at lunch today, Don Johnson. Don, where are you? Wanted to speak for a couple of minutes to the patient group in this room at lunch about the handbook, the Arizona Patient Handbook, which they've all created. I think that's just about all for now from me. So thank you very much.
Morning, ladies and gentlemen. This morning, I said morning, ladies and gentlemen. Anyway, sorry about yesterday morning, but we had some fun early before the meeting, which this morning I'm in charge. First 2 hours, you're stuck with me in charge. We are running to time. Anyone that doesn't run to time with a lecture they won't be asked back. Now, the first session is an information session. First is Brian Orr, the gentleman sitting over there, who is our Vice President that's in charge of the cancer program at our hospital. Brian has to put up with a lot, including me, and he does an excellent job for us, and he's going to talk about the challenges of actually running a nuclear medicine program and an oncology program that treats neuroendocrine tumors. Second is going to be Bob Thompson here, who's from the Ministry of Health. He's the gentleman I have to persuade that my patients are sick enough and need to go overseas for treatment. Excellent gentleman, and we have a very good working relationship. And the third person is standing in the corner over there, is Ian Mackay. I always call him Mackey, but he likes Mackay. And he's from Health Canada. He's the gentleman that runs the program that allows us to use the therapeutic agents that we treat patients with. MIBG and the radioactive Lipidol we use are not licensed in Canada, and under the Medicines Act in Canada, we can ask the Canadian government to have that waiver to allow us to treat patients. And Ian has been doing the job now for about 18 years, and we haven't killed each other yet, and they give us excellent service. We get an approval usually within 24 hours, providing the fax machine is working at both ends. So without much ado, I'll ask Brian Orr to come up and give a talk, please.
Good morning. Thank you, Robert. Robert and I have got to know each other quite well in the last couple of years dealing with our neuroendocrine program. So I'm going to make a couple of confessions to start, as I am probably the least qualified person in the room to answer any questions that have anything to do with medical impact or patients. I'm the bureaucrat this morning. What I'm going to do is talk about the fact that a couple of years ago, when we realized that we were having some problems with this program, we did a very extensive external review, including looking at other programs in other countries, and put together a business case to take to the ministry because we had issues around providing a program that was suitable and adequate to handle the needs of people in Ontario and, in fact, Eastern Canada. So what I'm going to share with you this morning is some of the aspects of that report. I won't be mentioning any names in order to protect the innocent. I won't comment on the guilty, Robert. They can confess their own sins. I think everything on this slide is self-evident to people that are in this field. This is a rare form of cancer. One of the challenges in a country that has the lowest density population in the world is if you have a very rare form of cancer, you need a very large geographic territory as a catchment in order for there to be enough patients to in fact support a program. Because you have to have a minimum number of patients in order to support the minimum number of healthcare staff required to do that. And that's a particular challenge. And it's probably one of the reasons we have only 2 programs in Canada and why we can probably only support 2 programs in Canada because of that. Another problem with being a rare form of cancer is that historically it's got very little recognition and support. Now, for those who don't understand the Ontario healthcare system, I have to explain how we're funded. The hospital gets a fixed amount of base funding each year to deliver a set of services, and what's happened over the last few years is we have accountability agreements that we have to live with, which say how many patients we're going to see and what types, and go there. You need permission to go up, you need permission to go down. And so that funding is based on the typical or average cost to treat a patient. And so one of the problems you get into is you can be considered inefficient if it costs you more than that to treat patients. And we'll get into that a little later. The only thing that we were funded for specifically in this program outside of base funding was the direct cost of the radiopharmaceuticals to a ceiling, and there has been a ceiling, although the ministry's been kind enough to move that ceiling up for us. But there has been a lack of profile both outside and within the organization, lack of understanding of this program, which leads to a lack of credibility, and means we're also competing with scarce human resources because the reality is what we treat on neuroendocrine means that other patients may not get that. It's not like we're just sitting around waiting for patients to come in the door. Just to give you an example, last year we had almost 7,000 new cancer patients in our center, of which less than 0.1% were neuroendocrine. It's also very labor intensive. This was not understood. We found in our study that the amount of healthcare worked hours required to support this program is double the typical for a cancer patient. That makes it a very expensive program to run. Get myself organized here. So, out of the report, we identified 8 key success factors because we said if we want a long-term, sustainable, viable program, what needs to be in place? And I'm not going to spend much time on these because we don't have time this morning, but obviously there needs to be clinical leadership. There also, what's not mentioned in there needs to be administrative leadership. You need a strong, experienced, multidisciplinary team that's used to working together with this group, and the nice thing about having a large enough patient population is they can then specialize and focus their attention virtually exclusively on this group, which is where you get the best care. Clear focused succession planning, because the problem with a small program is you don't have reserves, you don't have extra people trained, so when someone comes up to retirement or they get another job, you're suddenly left with a gap. And this is not unique to this program. Another one of our very small programs, bone marrow transplant, we lost 1 advanced practice nurse this spring. We've had to shut part of that program down for 3 or 4 months until we get that position filled and started up again. So it's not unique to this. It's a characteristic of rare forms of cancer where you have very small programs in place to do that. You need strong links and coordination between oncology and nuclear medicine. You need to be part of an academic comprehensive program. One of the things that we looked at is said you need to be doing research, you need to be learning from each and every case as you're going through this. There's just not enough patients to do traditional kinds of research trials. This is something you have to learn by doing. A reliable database to track all of that information, a proper register, ability to have a critical mass of patients, which is absolutely essential. And for us, a recognized province-wide program, and again, I'll stop for Ontario to explain this a little bit for you. We divided this province into 14 regions. Each hospital is supposed to be working with the region to provide the care needed in that region. The problem is, what do you do when you serve the entire province from one center? And that's one of the things we're trying to stress with the ministry, is that this needs to be recognized formally as a province-wide program servicing, and there needs to be funded based on the province's need, not the region's need for the care. Just to go on, since there's a lot of doctors in the field and they like data, I thought I'd share a little bit of the data from you. This is our average cost, direct cost to deliver the care for the 3 treatment modes that we typically run. Just to put this in context, the average cost per inpatient that we're measured on in benchmarks is under $6,000 per treatment or case. So that means that we're running slightly over twice the cost per patient to do this, and I said you'll find it primarily in the labor costs. So what this shows you is what the annual cost to run this program is for our program. It's a little bit over $2 million. What we get in base funding is equivalent to $1.1 million. So basically, this program costs us $1 million a year to run. And the point here is when you've got competing for scarce resources, that puts the program in jeopardy. A program that's losing substantial money is a program in jeopardy of being downsized, just because of the pressures and the way the rules of the ballgame work. The other side of this is how fast is this program growing? So the study looked and did what's called compounded annual growth rates, and basically I pulled 3 numbers out of the report for you. The number of patients receiving treatment has been growing typically around 6% a year because it's a very small population that bumps up and down. The number of treatments have been increasing at 10% per year, and if you want to know why, you can ask Robert. The number of patients receiving diagnostic and follow-up screening is going up about 9.2% per year. So this is a program, when you get base funding plus inflation of 3% and you've got a growth rate of 9 or 10%, that means we're getting farther behind in terms of what we get paid to do this program versus what it costs us to do this program. So this is the inpatient capacity. So in the business case, we said, the other question we want to ask is how many patients could we actually handle? Were we at capacity? What would be our maximum capacity in London? And so this is 06-07 data, which was the baseline we took for the study. And what you see there is, it turns out that we have 4 shielded private inpatient rooms on our oncology unit that we need and are essential for this program. And so we said if we use those at 100% capacity, how many patients can we handle? It turns out it's about 320. So we're at about 50% of the capacity that we could handle with current treatment mechanisms. And I think Robert will point out, if he hasn't already, is that there are some alternatives that would actually allow us to increase that capacity without expanding these rooms. And I can tell you, these rooms would be extremely expensive to create. They are full shielded rooms because of the radiation, and you just don't pop them into another inpatient room to do that. So the kinds of limits that we looked at, I would say the number one has been the funding. In fact, we've got a proposal in front of the ministry, and the ministry is considering this to ensure that this program can go ahead and grow to meet the need by being fully funded for what it's doing. So without that funding, this program cannot sustain itself and continue to move forward. There are some issues around clinic time availability. We've looked at that and said we can deal with that if we have to. There were some issues raised about our capacity and specialized diagnostic services. Again, that's another area that we've realized the hospital can deal without a problem. I mentioned the beds. They're fixed. We have to live with them. It's unlikely in the next 10 or 15 years we'd have a chance to expand those. The other was dedicated medical oncologists. What we found in this program is the workload on the medical oncologist is twice the typical load for a medical oncologist. So that means they can handle half the patient volume that the other medical oncologist can meet. And when you're in a system that rewards each medical oncologist on the number of patients they get seen, then you can realize there's a disincentive to want to be in this program. So they are on an alternate payment plan. So one of the proposals was to ask the ministry to fund adding an additional position at London so that we could in fact scale up the medical oncology without financially penalizing the medical oncologists for doing that. And they get really upset if I talk about taking money away from them. The other one is radiopharmaceutical production capacity. I'll talk a little bit about that in a minute, because that's the other one that we need to be very concerned about and unique to this program. As I mentioned, additional physician funding, because this is through the province. Funding for physicians is separate from the funding for the program. That's why we've been pushing forward to try and get the cost for an additional medical oncologist. I'll mention the GMP. It's my spelling late at night. GMP lab. We have managed to run this program by doing the radiopharmaceutical production in-house. One of the really interesting things we found in the study was, and that lab is no longer compliant with Health Canada requirements. They've grandfathered us for a while until we can get something in to replace it. But the impact, if we had to go outside and commercially buy the product ready to be used, as opposed to doing the in-house manufacturing of the final stage, it would cost us an additional $750,000 a year in purchase costs. We have been looking at raising money to do something about this, because we want to, in fact, replace it. So we've gone out and fundraised we've raised enough money to create a location and a facility for this lab, but we have not been able to raise the money to buy the equipment for the lab. So where the irony is that we need about $600,000 of one-time capital, which would save the cost of $750,000 a year. Now the irony for me is that doesn't save the hospital a penny, because we're only going to be paid for the actual cost of radiopharmaceuticals. It saves the ministry that money every year, because it reduces the cost of the drugs, so what they have to pay for on those drugs. So it's an interesting case example of who gets the benefit out of an investment. So these are what I see as the 5 major risks to the program, because you have to, I think basically what I'm saying is, because it's a small program dealing with rare tumors, it is always going to be at risk. You're always managing the risks of maintaining that as a viable program. There's no question about it. You can't get away from that as a problem. So I think the number one risk for us always is losing key specialists for whatever reason. They're a small multidisciplinary team. There are no reserves. We can't afford to keep people trained up as backups for people in this. And it's difficult to attract and train people, especially if they think the program's not going to be around. So the program, people need to believe the program's going to be there and be sustained. Loss of in-house radiopharmacy lab, as I mentioned to you, would be a huge risk factor for us. Insufficient funding would be basically a showstopper for our ability to continue this program. Insufficient staffing growth, because if we're growing at 6 to 9% a year in demand, we've got to be able to staff and grow the program at that kind of rate. And the ability to strengthen the academic program, it's something that is an issue for us, but it's not seen as a major issue, but it's something we have to deal with. So that's basically, in a nutshell, in about hopefully 15 minutes, a summary. One question?
On the slide, it shows the number of patients.
Yeah.
Well, the pyro patients weren't included in that total, so if you add the 30
Yeah.
to 40, it brings us up close to the 200.
Yep.
So there's less.
Robert's correcting me on the numbers, saying I left off some patients, so we're up about 200 on that. But as I said, it's late at night and doing work. Thank you very much.